I think almost all has already been said, but I think I need to inspire the physicians over here to understand that since the days of Grunsik, when we first did balloon angioplasty way back in 1977, and then continued to do primary PCI, which was brought to us by Bill O'Neill and Cindy Grimes, when they showed that doing primary PCI is much better than giving thrombolytic therapy, we still have very many unmet challenges and needs to deliver better flows, to deliver better myocardial blush and better ST segment resolutions. I work at a hospital which is a pretty small hospital in Bandra, but however that's the queen of the suburbs in Mumbai, and we have an excellent PAMI program that goes on. We have a hybrid catheterization laboratory where we can do surgery and angioplasty in the same suite. So we have a sited cath lab, and you can see that we have a program where we have nurses and technicians who stay on campus. So we're dealing with the primary angioplasty very, very often. There's a different approach in different setups, and I think Dr. Hiremat and Sunil Kapoor clearly mentioned that the saphenous vein graft was also looked at, and M-Guard is used in those situations. But I'm going to address the situation of primary angioplasty, and all of us have already alluded to the various methods of approaching a thrombus. It's been the Achilles heel of the angioplaster, and most of us have tried aspiration. Filters have not worked very well. There's now some new technology with a balloon called the Clearway balloon, whereby Greg Stone and others are doing work to show that drugs such as apiximab given through the balloon works better. Most of us are already aware that giving drugs down the coronary artery, for example, nitroprusside, nicorandil, and adenosine helps. And most of us can also be aware of the situation of the amount of thrombus that we need to face. But here it's clear, and I think most of us have already alluded to this, that TIMI-3 is good but not good enough. A successful angioplasty procedure, usually you need to avoid distal embolization. You've got to see that there's no reflow. You very often see no reflow. Your myocardial blush grades are poor. And all of these are very strong predictors of mortality. And so despite successful revascularization, so-called successful revascularization, 30 to 50% of the patients end up with a suboptimal procedure. And most of us know that if you have that, your infarct size is going to be bigger, your 5 years mortality is going to be worse, and so on and so forth. So this particular new concept of having the mesh to reduce distal embolization by trapping the material was in fact, I think, a very, very novel idea. And I have used this stent, and I can show you the case that I did. I've done a couple of other cases where I think large thrombus can be dealt with. I did a talk the other day for management of large thrombus, and I included the M-Guard in that talk of mine. This is the stent, and it's surprising to note that though it has this mesh, it's got a pretty good crossing profile. So it's not all that bulky. It goes down and tracks down arteries pretty well, and it's a stainless steel with the PET mesh on top of it. Most of it has already been spoken to. It's available in different sizes, going right from 2.0 to 4 and going from lengths of 12 to 39. So you have the stent available in many, many sizes, and already we know that this has been included in the European guidelines to be considered as a class 2B by C indication for highly thrombotic lesions. And so we have another approach. This was a patient, actually a 70-year-old patient, who actually had triple vessel disease when I angioed him. I'm not going to show you the left system because there was a long tortuous LAD and circumflex which we are going to tackle later. But his infarct was in the inferior wall, and you can see that there was large thrombus over there. After getting down the wire, I thought, now let's, we thought of thrombus aspiration first. That's the usual thing that comes to mind. And then Gunesh met me and said, why don't we try this new device? And it came to my mind that we could try this new stent-based technology to to take care of this lesion. We tried to get this stent down straight, but unfortunately, we had to use a small balloon to first dilate the lesion, because the stent, though it is good, we had a very tight lesion at that spot, and so we couldn't go ahead with the direct stenting. But in some cases you can. And if you can do that, then that's even better, because then you're trapping that material right up in front. We had to dilate in this particular case, and following that, we put in a 3.5 by, I think 30 or 19, I think a 3.5 by 19 millimeter stent down this artery, and very comfortably, very comfortably, we were able to achieve an excellent result with excellent flow down the artery. I hope it goes ahead. I don't know whether it is. To cut the, yeah, that's it. To cut the story short, what really happened was that the result was excellent. We had a TIMI-3 flow, we had fairly good myocardial blush, and this is a technology, I think, if it is combined with adequate pre-treatment of the artery, you have adequate drug being given down the artery to prepare the myocardial bed. I think there is now available to us a technology that will certainly take us to a different area, because I think the Achilles heel of angioplasty in a situation of STEMI is no longer restenosis. That's something which we are all dealing with already with drug-eluting stents and so forth. The Achilles heel of angioplasty in a thrombotic containing lesion is the thrombus. And if you can be, positive with that, and if you can somehow reduce your distal embolization, improve your ST resolutions, and take that forward, I'm sure you can deliver an excellent result in these patients. I thank you very much for your attention.